So today, as per the request of Dr. Saha, I have a hard cataract to show. And let me just share the screen. Okay, so this is actually not a brown cataract, but it's a cataract nigra. So most often, most people would prefer to do SICS in these kind of cataracts. But myself being a predominantly a phacosurgeon, I do take up such cases. But one must always remember that these kind of cases require a good viscoelastic. Your HPMC will not work alone. You need viscoat or oro coat. And your irrigating solution also must not be just BSS. Always use BSS. But for such hard cataracts, I use what is BSS plus, which Alcon gives, or we get glutasol, which means that there's glutathione mixed in the BSS to aid in the proper protection of the corneal endothelium. So let us begin this case. Side ports being fashioned with the 15-degree lance tip, air being injected in the anterior chamber, followed by trypan blue. And what you will notice in this patient is that in spite of the dye that is being used, there's hardly any contrast. When you once I begin the capsulorhexis, you will be able to appreciate that there is hardly any contrast available.
No fundal glow, you mean to say?
No, not fundal glow, but when you put trypan blue and when you raise a flap, you get a contrast between the stained and the non-stained part.
Yeah, you can differentiate. Yeah,
you can differentiate. But here, you will be able to notice that there is hardly any differentiation because of the hardness or the dense sclerosis that is there in this patient. So what I put
there is pterygium also.
There is a pterygium also, yes.
Actually, as you do the fluid air exchange, here you have to change the aqueous with the air. Then only there is no space. Otherwise, your dye gets diluted, doesn't have the time, and you have to put a little more time than the normal time.
Yes. But here you will be able to see that I've started with the cystitome, raised a flap, and there is hardly any contrast between the stained and the unstained. Slightly my hand is coming also in the view.
We are seeing now. Good.
So here I am trying to make a larger axis. It cannot be a 5.5. It has to be a larger axis, at least 6.
6.5.
And 6.5. Because in dense brown cataracts, one must try and have a larger axis. That is what is recommended. So here the rhexis, it's coming almost to the periphery here, and I'm finding it difficult to maneuver this flap. So I tried to persist, but then because of the loss of the view, I thought that it is better to use a forceps, and I tend to use the Haldi-Pucker forceps a lot. And there you can see that the rhexis is now complete. And this is followed with here in brown cataracts, I tend to use 2.8. Reason being is that the cataract is so hard that 2.2 or a 1.8 tends to get clogged, and 2.8 is a good bet. And because of the larger bore of the phaco tip there in 2.8, even larger chunks get aspirated. Otherwise, in a 2.2 or a 2.4, those chunks tend to get stuck. And that will increase the temperature at the phaco tip if the nuclear pieces do get stuck. So a good hydrodissection, as was explained yesterday, also a cortical cleaving hydrodissection. And again, this is Orocoat, no financial I tend to use Orocoat a lot. It's slightly cheaper than Viscoat. And this is a 2.8. So as has been taught to us that in these very hard cataracts, it is always a good technique to make a central crater. And that is what I am trying to do. I'm trying to make a central crater as deep as possible. This basically not only breaks the dense endonucleus, but also gives you a edge which you can hold, and then you will see me using that edge to basically and see what is there in my left hand. I'll go back. See this tip. This is a very sharp, about 3 millimeters in length, very sharp. This is what is actually needed for such hard cataracts. I use this only for very hard cataracts or for brown cataracts, not for routine cases.
Whose name with this chopper?
This is a sharp chopper which I got from Indo-Swiss.
Okay. Because now many choppers has some name. That's why I was asking which name
No,
this
there's
is.
no name to this. This is just a sharp chopper.
Good.
So what you will see is that I am using the edge of the crater to hold the nucleus and then create a chop. Since you have a larger size of the capsular axis, the chance of hitting the capsular axis margin is less. So one must try and get as much of a crack as possible, but if you don't get a through and through crack, don't worry. The initial step is to basically have a crack. There you could see that I had a through and through crack. Even if you get one or two through and through cracks, that is your starting point when one begins the emulsification part. So holding it properly and then chopping is the key. If you lose the grip, you saw that I was losing the grip, so I impaled again. You can always do that. You can impale and I will come out. Now this one piece is now free. So repetitive use of viscoelastic. So once I've done the chopping, then viscoelastic going inside the eye, Now this is a different chopper that I'm using. Now this has a blunt tip, will prevent any to the posterior capsule. The internal part of this has a sharp end, so that helps in the chopping of the fragment once bring it to the just above the plane of the iris. So one has to be slow and make sure that you are able to see what you are emulsifying.
This one is terminal chopper, a Terminator by Dr. Rajendra Prasad.
No, I have not used that.
No, not that.
This is a different.
This is regular blunt chopper with a little longer one.
Yes, and it has a sharper edge inside. The inside one has a little sharp edge, which helps to chop it.
Inside sharp edge is one with is the terminal chopper by Rajendra Prasad. What he says.
That is a big weight.
This chopper I have been using even before the Terminator was invented. So, everybody, gives their name to certain choppers, but this was available since a long time. In fact, this is third chopper of Dr. Pallavi, and she had bought it when she had completed her phaco training a long time ago. So the terminal chopper has come recently, but this has been there for a very long time.
In the earlier days of phaco, Dr. Kumar, he showed that flower petal for this kind of a 5+ nucleus.
Yes.
And he just make that time the basic thing was trench and do. So he did the partial trenches all around 5-6. And from there he separated the endonucleus. He took the endonucleus out, then it became easy. So that was first time innovation in hard nucleus.
Yeah, so this
that
technique
kind of nucleus Americans have not seen.
So in the end, again, I'm using Orocoat, basically to push the posterior capsule behind and protect the corneal endothelium. This technique that I am using is what Dr. Abhay Vasavda taught my father, and I have seen my father use this technique in all brown cataracts, and this is what I almost routinely do now.
What is the technique? What exactly you are doing?
This is a simple central crater and chop. Central crater and chop.
Okay.
This is what Dr.
The classic way. Okay, fine.
Yes.
Crater and chop is very renowned now. It's very.
That is classic. Huh? And one point about the people who are not having that feel, though after doing CCH should use both hands, because many of these hard nucleus has jonules are poor or weak. So if you do in one hand, there might be little uneven pressure, and that can cause mild thing to moderate to severe. Both hands, the pressure is balanced. It is just wheels like a driving wheel, not wedging on one side.
So last piece, I'm trying to be extra cautious, but still I had a bit of surge.
Beautiful.
So this is what I wanted to show. Rest everything is same. So
discharge होने वाले के वैसे.
Okay, so this was the very hard cataract being managed and successfully done without any complication. Your comments, Dr. Pranaranjan sir.
Very, very well managed. I mean, just a few tips that I can also share, because what I saw, you did it fantastically well. The nucleus management, basically what I do, I do a stop and chop technique for such cataracts. Make a deep trench, debulk the central part, and then rotate and divide it into four halves. Again, divide it into halves. That means altogether 8 halves, just like the orange this thing. And then take the pieces one by one. This is what I've been doing, and that has given me reasonably good results. So it's basically making the nuclear fragments, making it into pieces, small pieces, and then taking out one by one. That is what I have been practicing.
So, I mean, the most of the people who are expert in phacosurgery take care of such nuclei. But what
direct chops, I have totally stopped for these kind of grade 4 cataracts, brown cataract, what you showed. I mean, probably direct chop will not work. So you have to debulk the central area, make a trench, a deep trench, and then redivide the nucleus into multiple pieces.
okay, so
No, are you saying
And
deep
that is
trench
probably
or
what
deep
you did.
crater? Sir, you are saying deep trench or deep crater?
deep trench.
Deep crater.
Deep crater.
Deep,
It's
deep.
not trench.
Not-
Basically, the endonucleus to be taken as much as possible so that the
Yeah,
basic heart is out when your
You break
plate is your posterior capsule. So if
Yeah.
you don't put a posterior capsule and you go in anywhere with the triangle, the wedge out, then you are in real problem. So here, keep the whole outer cell and take care of the inner endonucleus. Then the energy, whatever, it still is centralized there. And then go ahead. Chaliye.
Yeah. So, but I wanted to know about the use of Viscoat or Orocoat or BSS Plus or Glutasol. Do you routinely use these?
I routinely use in all cases. In fact, no matter what, whether it is soft or hard, I use a soft cell technique.
Okay.
Soft cell technique basically is sodium hydrogenate and chondroitin sulfate, that is Viscoat, or any other Indian brand, Orocot or whatever it is, with a methyl cellulose.
Fair
Dr.
enough.
Shalabh, I wanted to add some things.
Yes.
Actually, your technique is very good, but there are few other ways which are shown by other doctors also, and I keep on trying every technique. So
Right.
crater and chop is a good method. Then there is one technique by actually the important thing is that you have to break the posterior plate in these cases. So one good technique is shown by Dr. Uh, Devgan, Uday Devgan. So I watch his video on cataractcoach.com. So so he has shown that in these cases you have to make a very big rhexis like you have shown and prolapse the one pole of the nucleus and impale the nucleus and
Yeah. So
with the chopper you have to go posteriorly and then break the posterior plate.
yeah,
So that is one way.
No. The problem with the bringing such a hard nucleus into the anterior chamber,
No, you have to bring it partially.
even partly. Why do you want to bring it partly into the anterior chamber and risk greater amount of endothelial cell trauma?
No. Once you get the break starts, once the crack starts, then you can reposition it, and then you can do normally also. Like you don't have to follow the whole thing.
Yes.
Yeah.
It is difficult to do. Dr. Keki Mehta also has shown many times. Somehow, rotating and bringing it even one pole into the anterior, above the iris, above the rhexis is slightly difficult. And as Dr. Saha mentioned, biggest problem with these cases is that they have weak zonules. So
Yes.
tumbling or trying to bring it into the anterior chamber or even partly.
Indian brown is very, very advanced, and black, it is almost impossible. So that's the actual status. Once you are having like the instead of Maruti, you have the best car, then you can go ahead with that. That is one.
Exactly. So,
And second, here the Jonule's capsule is very weak. So here nothing, no pressure, anything which you do in SICS, nothing there, so that we can handle them. And I personally felt at that time that flower petal was very good, but then with this newer ways of doing it, okay, the indirect chop has more power, so we do this central part debulk, then indirect way off. That's my way present now. I don't know.
for
And one
nuclei,
more,
for nuclei which I showed, that was a absolute, black cataract.
Yes,
These are the kind of cataracts we routinely get, the dense brown cataracts, which are not as dense and hard as what I previously showed. So here again, a small little crater, and then the direct chop. So it's not as if the direct chop doesn't work. It does, and I think that use of such a chopper, specialized chopper, helps you to chop it properly. If the chopper is small or not as sharp, this is where I used to struggle. I didn't have this chopper. I really used to struggle with being able to take this nuclei right the posterior plate. So I think not only the phaco, but also the chopper has a very important role to play. And I haven't really seen people talk about chopper unless until it is by their name. Nobody talks about the chopper, where to use
no,
which kind of chopper.
here it
this
is
kind of
chopper.
chopper I use regularly. I got it from the Upper Sami, the similar kind of chopper, very
Yes,
sharp,
very
and
sharp.
that I use it for cataracts. Upper
Yes,
Sami.
Here it is chopper, phaco only to hold it, nothing
only
to
hold the bullet.
phaco it out. It's
Yes,
to
yes,
hold it and break it with the chopper. Your left hand does more work. And some people who have ambidextrous, they do this with right hand, if the right-handed person, and left hand only to hold.
yes.
So that's the exact thing in these black cataracts.
Yes, so this I wanted to show that even if you don't make a very big crater, you can still chop it and get these multiple fragments and chop it into multiple
Yeah, you managed so well, so
segments.
beautifully,
Yes,
fantastic.
And tell her what you showed. Once you make the fragments 8 or 16 divided into fragments, you change the chopper.
yes,
You use I use a blunt chopper after that.
yes, yes. Always a blunt chopper because the chances of the
That is to save that
posterior capsule
posterior capsule.
in these brown cataracts really tends to jump. They don't stay
And
back. They don't stay back.
Not
thirdly,
for
when
you,
I'm
but
taking the last piece out, especially the last piece, I tend to put the repositor in between the phaco tip and the posterior capsule, and
Yeah,
in between both of them, I keep the fragment,
yes,
so that even if
that is something I learned from Dr. Subhash Prasad. He had
yeah,
shown.
I do it in 90% of the cases.
Okay.
Last
Yes,
piece, I'll always put the
yes, very true.
uh,
Very,
that becomes very safe.
very safe.
one more extra protection, like when you took the first wedge and other things are not broken, at that point the posterior capsule is bare there. You injected
Yeah.
viscoelastic to protect the endothelium, and that is good, but as well as to put a little there in that gap does two things. It protects there also and it goes behind also. So
Yeah.
for
Yes,
not so smart doctors like you, they will be helped a lot by just simple thing to put viscoelastic in that gap.
yes, I have seen this recently shown by Dr. Arup. Uh,
Mhm.
in a conference, he had shown that you just put a little bit of the cohesive viscoelastic just in that gap,
Mhm.
and it just pushes the posterior capsule behind and slightly creates a space uh, in these kind of
That's the thing. These are
cataracts.
the small
Yes,
pearls and they really helped a lot, especially in this
Yeah.
critical situation.
All
yes,
yeah.
yes, yes. So anything else? Any questions from anybody?
Others are all silent,
Alan,
and
you-
the people are conspicuous by absence of their face. I don't know their face at all. I am new here.
Alan, we need to circulate it more to the PG level, to the medical colleges.
Yes,
to
yes,
regulate
I'm sharing the link to Dr. those who are in IGMS and to DMCH.
You have to contact, you have to
Yes,
personally
basically,
contact one of the influential people of the medical college, tell them that you are doing this, and tell them that they can pass in this word so that the
yes.
residents and others also can watch it, because this is really good. I'm keen on watching it, even after doing so much of investing so much of years in this surgery. So why not the young people?
Exactly, exactly. So hopefully by the second week of this series, we will have more attendance. Dr. Anita, any
I've shared the
comments?
link. I've shared the link, and I have told my postgraduates to to watch, and it seems they're
Big in
bogged
other
down by too
things.
many things. They are bogged down by too many things. They have
Anita,
so many.
this is a direct interactive kind of a thing, not that 100 people are watching. So
And
any
like
small
this also two other thanks, Anita Devi. I could see you. And now there is
clarify.
one Jha and
Because of what
Rajasthani
you said, I turned on the video.
still conspicuous by their facial absence.
I thought you
So,
might be suspecting that we are not there. I've been listening.
no,
Any-
like this is the Zoom conference. Normally, when the surgery goes on, okay, no problem. But after the discussion, unless there is face to face, there is nothing. So it is just the words, the energy involved in it.
Yes.
So any comments from your
When
side, Dr. Anita, about this
Dr.
brown?
Lab, you did the surgery the way I do. I make a crater, and I use a very sharp chopper for this, and this is how I do, except that I don't change it. I continue with this. And I'll tell you interesting thing. Once when it was in a soft cataract that I got the chopper, I didn't check it, and it cut beautifully.
It cut
No,
everything.
but Anita, you
No
should change
need for any
the
chip and flip, Otherwise, I would be, just eating up, and then I'll have to, flip in the soft cataracts. And I was like, "What is this chopper?" And then I said, "My God, why have you given me this chopper?" Then
So
I just
before,
tried it and a few more soft cataracts, and it was like, it goes right in even, and it cracks it.
yes,
Although
so
we tend to
one,
use it in the harder cataract. So I use I have a very sharp chopper which I use, and I also make a center crater, and then I chop. And of course, another part is that sometimes you have this posterior plate, and then sometimes you just end up with a petaloid like structure, and then you have to
yes,
finish
yes,
up the center part. The center part first, hold on to the center part, finish it off first, and the rest of the petals come apart.
yes, yes.
Anita,
So
if the central petal part is there, you can leave it there and take it at the end,
At the
flip
end
it
also.
and bring it. Yeah, at the end also.
yes,
This is sometimes because no surgery goes the way it is written in the books.
Yes.
It becomes
yes,
a
it
mix
doesn't
and
go
match.
exactly.
Chop,
Yes,
this and that. Yeah. Ultimately, you have to know all the techniques, and you apply
Very,
all the
yes.
techniques with such kind of cataracts. It's not
very
that
interesting.
one defined line you have to follow.
Very interesting.
Isn't it?
What
You know,
And
what
and,
towards
and,
sir
and
has
Anita,
said,
you must try and change the sharp chopper into a blunt chopper towards the end. It will
Yes,
give you
yes.
more confidence.
I think it's more because of laziness than anything else. But
No.
you're right. It should be
I
changed.
have, I have,
It should be
I have a
changed.
small thing to add here.
I'll
Like
change
the
from this time.
when Akahoshi came with his pre-chopping, then he used one chopper, which is like a ball and big curve like this. So that is very good in this kind of situation when you have a very big things and you don't want anything to go on the posterior capsule. Use that. You are protecting the capsule and holding the things out up, and that only can hold that. Akahoshi's chopper and the holder, that holder one. It's a big
yes,
one. It's a big one
yes,
and a ball. That
yes, yes,
ball cannot damage the capsule.
that is a preferred
The,
chopper. There's a Brazilian surgeon. I'm forgetting his name.
Netuseli, whatever
Ah,
that is. But
yes, yes, yes. Rosalie.
No, that is actually modified of original Akahoshi. Akahoshi was the first one to do proper, and he was doing the surgery at that time 3 minutes. That was world record. Okay, so he has that sustainer holder, so that will not damage capsule. But
Yes,
it was very good, and I have still am having that, and whenever in this kind of thing I use that. It's very good.
Another tip that I saw Dr. Pratho Biswas sir giving was that if the posterior plate doesn't break and if the fragment can be brought a little above the rexus margin, you can harvest, like he used to say, it's a harvest technique. Just cut the
Exactly.
posterior part of it.
Harvesting is a very, very good technique for these kind of cataracts.
Yes. So
You
if the
slice
posterior
it
plate doesn't
and then you
break,
cut it. Yeah.
the posterior plate doesn't break, don't worry, hang it up and just like जैसे धान काटते हैं उस तरह से आप उसको काट सकते हैं नीचे से. That is what.
No, what technique is very, very, very useful.
Yes.
That
So
technique is useful in petal form. That
Yeah,
yes,
yeah, yeah.
once you've
That's
got
the thing,
once
yeah.
you've got your petals, and if the posterior plate hasn't broken, you can
The
bring
two
up
things
one
there,
petal
two
one
things
by
there.
one
In the
and just
petal,
harvest.
when you have the petal, you always put the viscoelastic behind
हसिया
the
से
petal.
हसुआ से काटने वाला बात हो गया.
एकदम हसुआ ही है.
So your chopper is then the
पहले
haswa. Your chopper is the haswa.
पहले
And
पीछे
that is where this
viscoelastic
kind of
डालिए.
chopper that I have shown, the blunt edge as well as sharp inner part, the harvesting becomes easier with this because the inner part is sharp.
Exactly.
No,
So
I was just telling
Even
this small thing. If once you have made the petals, the endonucleus is out. You just hold any of these petals opposite to your entry point, and then suck it out. And
Suck
because
it
you have
out.
put viscoelastic behind it, so it is now firm. So now you can eat just that, or you can use your left hand to pull it out. Now, as he told at the beginning, Parijat, that we should bring it out into the antechamber. Here you can almost make it straight. That salute of Kaiki. So once it is saluting you, now you start doing your right hand business and left hand just to hold it. The two small changes at stages, nothing more.
yes. So
just
that is when you have much of the endonucleus has come out, and you just have
Not much, totally. You take the endonucleus out, you are safe.
yes.
You leave two things mixed, you are in problem. You don't know where the nucleus ends, where the softer one comes. And your posterior capsule is softest. So that is danger. So don't do that. So you take the endonucleus out, leave all the petals. And
Yes.
now it is protecting your posterior capsule. If it is weak zonules also will not be dislocated. Once that is done, then you suck it, any of the petal, and it is now saluting you, pulling it out. At that time, you are pushing the viscoelastic behind. Then whatever technique it suits you, do it. No problem.
Yes.
Right.
just
Pranita,
what
do you
Pranav
remember
sir
there
was
used to
saying.
be,
Yes, Dr. Anita?
I think Dr. Parjat is saying something.
Actually, just what Pranav sir was saying, that you have to try various techniques, and whichever suits you have to stick to that.
No, case
One
per
more
case
technique.
also you can vary. Case per case.
Yeah,
You can
case by
vary
case
each
also you
Case
can
per
vary.
case,
Yeah.
even in one case, you can apply multiple techniques.
Yes.
Multiple
So that is
techniques,
why
yeah.
I said you need to know almost all the techniques, so
All the
that
techniques,
whenever
all.
at that stage, whatever is required, you do that.
Yes.
Even 4 quadrant with bigger trench, bigger grooves, that also helps a lot. 4 quadrant.
But
Yeah,
you
yeah.
will be using much more energy. So the energy, cumulative energy will cause endothelial damage, short term and long term also. And our Indian lenses are really hard. It's not American lenses, not the blue IEDs. So please be extra cautious seeing their videos and then translating here, not good. And our surgery based on physics. If you know the physical principle, we are smart enough to use it at that point of time.
Okay.
At
So
this
last
stage.
30 seconds remaining of the meeting. Thank everyone for being present today.
So
And thank you
we
for
have
the
it tomorrow also.
no, sir.
We have it tomorrow also.
No.
Okay, right. So
for tomorrow
give the
and day
link
after.
at least 4 hours before, so that I can place it in the ISOC platforms as well.
Yes.
Yes, I was sharing it. I have been sharing it in the ISOC main group.
I mean, we are getting only in the one ISO group. There are around 12 ISO groups, different ARC
wow.
and other things, right?
12
I've got
ISO.
access
So
to
what's the
all of
party
them.
there?
Okay,
So I can do that. I can do it for you. Don't worry.
okay. Thank you. Thank you very much. Thank you. Good night, everyone. Thank you very much.
Good
Okay,
night.
good night.
See,
Okay, good night.
today out of your 8, 5 were actively involved because you were showing something everybody was thinking. That's the thing I was telling you, that give something for everybody to think and participate.
Yes, yes. Thank you, Dr. Naveen, for
You saw
joining
the
us
response
today.
exactly.
Okay, bye-bye. Good night.
Good night.
Bye.
Good night. Hello, Jindabad.